Well, good morning. It's Tim Cote on Chapter 11, Lecture 11, which is Chapter 17 on international regulation. So we're going to talk today about the way that drug and device and food regulation cuts across and is done on a global basis by other agencies in the world, and also a little bit about how FDA deals with both the importation and the exportation and the relationships with other agencies. That will be our topic for today. There is also a assignment of Chapter 18, Fundamental Issues Facing the 21st Century Drug Regulation. This is written by Michael Taylor, who's now the Director of Foods at FDA. He is a highly eloquent speaker and a great strategic thinker about the process of drug regulation, because that will deal with your final exam question as well. I'd ask you to do that. I am not going to review that because in many ways it's a thought piece, and I want you to read it in order to get yourselves thinking about how to answer that final exam question, which will be placed up shortly, and you'll hear more about that shortly. Okay? So, medicines, foods, medical devices, they cross borders. Things are imported, things are exported. We live in a global world. You hear this again and again. More than half of you all are global. So how does FDA deal with that? We're going to talk today a little bit about other countries' systems. The US, the EU, and Japan are the major regulators of the world, and many of the smaller countries retain autonomy. They have the legal rights to register or not register drugs for availability for their citizenry, and often they don't have the capacity, the review capacity. So we can talk a little bit about some of how they look to the EU in particular from some of the African countries, the US for a lot of the Latin American countries, to decide whether or not to register things in their own country. The EU is the European Union. It talks in the chapter a little bit about how that's different from the European Community is the formal term. The Union is the philosophic term of a greater unity within Europe. EU law has developed on drugs. All of these materials through both case law, that is judicial decisions, and the European Community Treaty on Interstate Commerce, which is similar to our Interstate Commerce Clause. And so there's been harmonizing legislation between the two states, between the various states of Europe, Spain, Portugal, you know them all, okay? Going eastward. Article 28 guarantees the free movement of goods, and that's a fundamental concept in this process through which laws have been generated to harmonize and courts have been adjudicated. There was a very famous case which was referred to in your text on Caisson de Dijon, Cassis de Dijon case. This is an alcoholic liqueur which was exported, I think, by the French and imported not refused entry by the Germans because it was said to have too low an alcohol content, and there was some law that in Germany that's the alcohol content had to be this far. Germany made the case that even if it were a domestic producer, it would be banned. In Germany, France actually ended up winning the case. So the European court systems have again and again upheld this notion of the free movement of goods, and that has knit the European community much more closely together in the past years, the current economic crisis notwithstanding. As for harmonization, you need to know that in 1985, the European community passed a treaty that put up about 300 different measures that were all to become effective December 31st, 1992. They were pivotal measures that would knit the community together as a single economic entity. And those rules were called EC 92. In 1986, they also eliminated the provision for the individual member states to veto particular pieces as well. So they're not able to just pick and choose anymore. The whole sum of this is that Europe is becoming increasingly knit together in an economic sense with the free passage of goods from place to place and the regulation of those goods, including pharmaceutical, medical devices, foods, cosmetics, falling under those things. 1995, EMA, was officially called, originally called the EMEA. It's always been the European Medicines Agency, but they had to pick which abbreviation to use in which language. So there is a central expert body which makes a recommendation with regards to the marketing approval for drugs and devices, and that is called the Committee for Medicinal Products for Human Use. And the abbreviation for that, in whichever language, is the CHMP. So the CHMP is the pivotal body of the EMA. There are also decentralized, so that utilize the EMA's CHMP is the embodiment of the centralized procedure for the approval of products. There is also a decentralized procedure in which a sponsor can go to an individual country, secure approval, but if that is used for many different countries, there is that decentralized procedure is backed up by an arbitration process which is administered by EMA. You need to know that the EMA's central processes are administrative, and most of the technical strength for review actually exists in the member states. So Britain, France, Germany, Italy, Spain. That's where the reviewers are with their own national authority. EMA knits them together and says, okay, this particular application we'll send out to our reviewers, blah, wherever, because they happen to be the best suited for doing this review. But we'll process it centrally. We'll evaluate it as a body, as all of Europe. But still, most of the technical resources are coming from the individual countries. There is data exclusivity, much as we have here in the United States, like the Hatch-Waxman Act. Their form of data exclusivity is called 8+2+1, and that means that for 8 years after an innovator comes out with a new product, you can't file a generic application. For 2 more years, you can't actually market the thing. You can file the application, but you can't actually market the product. And you get 1 additional year of waiting if that authority has come up with another use for that product during the 8-year initial period. Okay? European devices are regulated in a very distinct way, different from FDA's PMA and 510K that we talked about earlier. There are directives that establish essential requirements, and they have to get the CE mark of conformity. That's a conformity assessment, has to occur for high-risk devices, and a safeguard clause allows for national enforcement authorities to use in extraordinary measures. You know, if there's something that comes up that they, a particular country said, we got to have a ban on this, then they can do that. High-risk devices require interaction with notification bodies, and these are quasi-governmental organizations that are set up in the individual governments, and they use the ISO 9000 system much more than we do here in U.S. regulation. Cosmetics, in 1976, the first directive issuing labeling and restriction on certain agreements was issued. It affirmed the listing for specific categories. There is a very controversial ban for Europe on the animal testing of cosmetics. We have very different philosophies on this, and I can talk a little bit more about the philosophies and the approaches and the way that drug regulation, device regulation, food regulation reflects our own cultures When I was at the agency, I worked a lot with the Europeans, and in truth, I honestly didn't even know I was an American until I spent some time with the Europeans and recognized how distinctive our cultural approaches to regulation are and how that reflects the places that we came from. Foods in particular have had less harmonization than drugs and medical devices, probably because they are so um, deeply a part of our culture, our everyday, for every person culture. So foods are a less harmonized component. Again, that free movement principle is the one that underlies most EMA regulation. Okay, let's talk about our chilly neighbors to the north, the Canadians. They are regulated by, well, Health Canada is the national, that's the equivalent of the DHHS for us, and their equivalent of the FDA is the Health Products and Food Branch. They do maintain a pre-market approval, but they look mostly not to the south, but over to Europe for their device regulation and for some of their drug regulations as well. The ISO 9000 is readily employed in Canada as well. Over and the land down under, Australia has the Therapeutics Goods Administration, which is called TGA. TGA is the equivalent of FDA. Well, it doesn't include food, but it's the equivalent regulator for biologics, drugs, and medical devices. TGA has a mutual recognition system with the EU, and we'll talk a little bit more about mutual recognition. Is this in our future? Are we going to be able to eliminate having parallel systems that look at the same data and usually come to the same conclusions, but sometimes don't, and often have different requirements for the data that are submitted to each of them? TGA had mutual recognition with EU concerning medical devices. And then Japan. The regulatory body in Japan that's most closely similar to the FDA is the Ministry of Health, Labor, and Welfare, or the MHLW. Pharmaceutical affairs laws governs drugs, devices, and cosmetics, but food sanitation laws governs foods. And cosmetics there actually require pre-market approval, unlike here in the United States, where they don't. Your text talks a fair bit about FDA regulations regarding exports of drugs that are not approved in the United States, and tracks the history of back and forth of it being allowed originally in 1938 by the law, by a very narrow reading of the law, FDA's interpretation that it was prohibited and for many decades not allowing it to occur. 1968, we had a special, a lot of concern about dumping of unapproved products in foreign places, and special procedures were set up for the FDA approval of banned products or devices to try to mitigate that. 1986, there were export amendments, re-regulation, and we were in a deregulatory phase in this country, and FDA permitted the export of some unapproved drugs. In 1996, there was another amendment which lifted the import re-export ban and allowed exports of unapproved drugs if it's currently approved in the outside country. So the take-home message from all this is that over the course of history there have been some changes with regards to whether or not FDA will allow drugs that have not approved for use here in the United States to go out or not. And there have been several iterations of regulatory instruments and legislation and regulations, and that has changed from time to time depending upon whether we are in a regulatory or a deregulatory phase in our political milieu. International activities, FDA engages with outside regulators quite frequently. The tripartite meetings refer to FDA's interactions with the UK and Canada, and those have gone on for some decades actually. WHO, FDA engages with them, and particularly in their activities on adverse drug event collection. There is a clearinghouse for all adverse drug events. Even though FDA collects adverse drug events as part of post-marketing surveillance, it and pharmacovigilance, those are all synonyms pretty much. It still collaborates with WHO in their activities, and regular meetings with the European Commission and their employees, and of course the EMA. There are memoranda of understanding with foreign regulators to try to work together on common problems, especially with regards to the inspections of foods and the inspections of products. Now, those memorandum of understanding are held in some sort of legal uncertainty because they're not actually treaties in the formal sense by which our Constitution defines treaties, and they cannot in any way abrogate or go contrary to U.S. law. But there is this effort at harmonization, and the Codex Alimentarius is a very old effort at harmonizing food laws across various countries. But the one that affects us most in the pharmaceutical industry is ICH, the International Conference on Harmonization. I've been to this a few times. It is the EU, the US, and the MHLW, Japan that is. It is not about mutual recognition. It's not, let's all get together and decide, are we going to be able to, if you license it, then I'll license it. It instead digs down into the technical requirements on a number of different fields, including safety and tox testing and efficacy and quality and adverse event surveillance. There is a medical device task force separate from the ICH, which is another effort at harmonization. And some of the broader treaties, like the GATT, the General Agreement on Tariffs and Trades, and NAFTA, the North American Free Trade Agreement, speak specifically to this big question of how do we allow for the free movement of drugs, of goods across borders without imperiling lives and respecting the autonomy of individual countries which have different laws regarding all this. So with regards to mutual recognition, FDA has traditionally opposed it, has really not wanted to get into the business of, okay, the drug is approved in Europe, so it should be approved here. And you should know that a drug's approval in some foreign country has absolutely no standing with regard to an application for approval here in the United States. None at all. Basically, we take a very parochial view that everything ends at our borders, and it's approved or it's unapproved. It's never, oh, it's approved somewhere else, so it must be. That has no weight in the decisions. Now, I will say that often decisions about approval between FDA and EMA will occur simultaneously. And conference calls do occur between the CHMP and the FDA. That's the component of EMA that makes these decisions, and the FDA. And those conference calls will get down into the weeds on technical issues, and usually they will come to similar conclusions. However, this is not required, and it's really not necessarily approved. Even in orphan drug designation, there is a common application now which can be sent to either the FDA or to the EMA for recognition of a product for orphan status designation. But the processes are completely independent. And I can tell you that I've many times in my capacity at the Office of Orphan Products Designation went to the COMP, the Committee on Orphan Medicinal Products, sort of parallel to the CHMP, which reviews them for marketing authorization. This reviewed them for orphan status designation. And there's a very different mentality about this. And like I said, it's reflecting of our cultures. We Americans come from the land of John Wayne. We give a guy a gun and we tell him to go out and make decisions. And I was in that seat. So I had a staff of 45 people or so, and they would come to me, tell me what they thought on individual designation issues, and I would make those decisions. But I was solely responsible. Well, that is not the way it is done in Europe. Europe is a very process-intensive communitarian environment. So when they need to make a decision at the COMP, they fly 45 different member state representatives into London, into Canary Wharf. Everybody gets in a big meeting, and some people have been assigned to be the reviewers on particular applications. They present the results and their recommendations, and they have a big discussion about it. Ultimately, they have a vote, and the community decides as a whole as to whether or not it is going to be granted orphan status designation or not. Okay, so you can see that there's a very different process between the two. The FDA has a hierarchical governmental structure in which people have bosses. There are these different layers, but and they function as a working community. The EU functions much more respectfully of each individual member state's input, and that's just a different way of doing business. In truth, actually, we compared the decisions that were made between orphan status designation in the US and in the EU and found a very high level of concordance, about 90% concordant. But I will tell you, it was painful to sit through some of those meetings where people are arguing and fussing and this all of this this business of flying people in and flying people out when really you just need one person to make a decision. Well, that is, again, reflective of these two agencies reflect differences in nationalistic cultures, the ones that we have here and the ones that they have there. Okay, so that concludes the final prepared YouTube video for this talk of Chapter 18. I want you to read as well. As I mentioned, I think it's an excellent, superb, forward-looking thought piece. It is not going to be something that I think is especially useful for me to describe by YouTube, so I'm not going to do that. But it will be useful for your final exam. So take a look at that, and we will see you at the foothills of Claremont. Okay, take care. Bye-bye.